Good morning, Chairperson.
Yes, good morning.
Okay, just wanted to make sure it's Henrietta Bokopane Zulu. I just wanted to make
Oh,
sure.
Honorable, yeah. Welcome, thank you.
Thank you.
It's great to have you in the meeting. I thought usually when entities are presenting, you find that members of the executive sometimes may not be there. We really appreciate this. Thank you very much. I want to remember that's the agenda. Any mover for adoption of this agenda?
I move for the adoption, Honorable Chair. It's Nkosi.
Thanks, Honorable Nkosi. Apologies. I'm told we have two apologies. Honorable
Baha seconds, Chairperson, the adoption of the agenda.
thanks, Baha, for seconding that. We've got two apologies of Honorable Lutuli and Honorable Christians. Those are the ones I know. Are there other apologies, Marcel?
Chairperson, those are the only two apologies. All of our members are in. Thank you, Chair.
Thank you very much. Like I said, let me welcome everybody to this meeting. I think this is the first meeting of the where we sit with the new board of the authority, the Central Drug Authority. And we meeting the last time. I think I'll be meeting with you for the first time because I don't think I've interacted with the new board since it was appointed, and that it was appointed during the term of our departed beloved Honorable Gillion. And because we are meeting for the first time with you since her passing, I'll ask members to take a moment of silence, at least to give those who were not there, those who could not give her that salute, to do that now in honor of Honorable Great Gillion. Thank you very much, Amanda. Today we will be receiving a briefing from the Central Drug Authority on the annual report 2021-2022 and an update on the drug master plan. And then after, so we'll give the department 2 hours, that is 10, 11 until 12 o'clock. And then we'll engage. And then from there, we'll release the department, our guests, and also so that we can deal with housekeeping matters in the committee. Thank you very much. Can we give the ministry a chance to address us and take over this process of the presentation? Thank you very much and welcome. Mebokopane. Just introduce your team and then so that we are taken through the briefing. Over to you, Minister.
Thank you very much.
Oh, she is in the meeting. Minister, go ahead.
Yes, good morning. Good morning. I am in the meeting, but just for the opening of the meeting, I have a cabinet committee meeting that I will join. But I thought it's important for me just to come here, and I know that the DM is in the meeting, and I know that part of the work that the DM has to do is what brings us here today. So my network is not very good. So if I can please remove myself from the camera, but at least you can see it is me. And then I will go immediately into the into opening remarks, and Chairperson saying that I cannot be here throughout the meeting. I will stay as far as I possibly can because I'm also in another meeting of the UNDP, but that one is done already, and then I'm traveling to the Cabinet Committee meeting. I'll connect until I get to the Cabinet Committee meeting. So, Acting Chairperson of the Select Committee on Health and Social Services, Honorable Mama Hassan Chabeleng, honorable members of the Select Committee on Health and Social Services, the Deputy Minister, of course, who is here, the Acting DG. I'm not sure if the Acting DG is here because also the Acting DG has got, is not very well. He had a very bad flu, but besides the flu, the Acting DG has got a new set of twins, of children that he has to take care of. We congratulate him on that. Members, Chairperson and members of the Central Drug Authority present here, and I wish to thank the Chairperson, and in particular, and the entire CDA. It's not long ago that we had a meeting and we were able to deal with some of the challenges which I think will be presented here, but also it's not just about the challenges, it's also the work that the CDA is doing, and ourselves as a department as oversighting, and the good work that is being done by the CDA in general. I wish to thank you for the opportunity to brief the committee on the 2021-2022 annual report on the Central Drug Authority, and to provide an update on the implementation of the National Drug Master Plan 2019-2024. I want to start by thanking the Chairperson and members of the Central Drug Authority for their individual and collective contribution towards addressing one of the most pernicious challenges to emerge in recent years. The World Health Organization estimates that every year, some 3 million people around the world die due to substance use disorders. That counts for a staggering 5.3% of all deaths. Latest data from the World Drug Report indicates that drug use across the globe is on the rise in terms of both overall numbers and the proportion of the world's population that use drugs. South Africa is no exception, and I'm speaking to people who see it, who feel it, who live it, even within their own families and their own communities. One has to look no further than watch the local television channel Moja Love to realize that our country is under siege from the illicit drug syndicates. The threat posed by the scourge of substance abuse and abuse in public health is public health challenge that remains visible in our neighborhoods and many parts of our country. Never before has action of substance abuse been so urgently needed than it is now. We are the first to acknowledge that must be done, and we must do better than what we have been doing in the past. As the Minister of Social Development, I've said to the department, we need to deal with this scourge, just like we need to deal with the scourge of gender-based violence, house to house, street to street, community to community. Because if we sit at the top and we think we can pass the legislation, develop the plans, and not be on the ground through ensuring that we strengthen local government structures, we strengthen community-based organizations, we support individuals who stand up and do something about it, then we'll end up with beautiful policies and beautiful legislation that does not have the necessary impact on our people. And therefore, the task of gripping the issue of alcohol and illicit drugs cannot be undertaken by any one department alone. A collective effort is required, which is why we have established the CDA in terms of Section 53 of the Prevention and Treatment for Substance Abuse Act number 70 of 2008, to oversee and monitor the implementation of the National Drug Master Plan. The CDA is structured in such a way that it provides a whole of government and a whole of society approach that focuses on the following strategic priorities: demand reduction for illicit drugs, breaking the illicit drug supply chain system through proactive law enforcement, effective response to drug-related crimes, countering money laundering, and promoting justice cooperation, increasing the availability of and access to drugs intended for medical and scientific use, identifying trends and control new psychoactive substances, promoting governance, leadership, and accountability for an effective response, strengthening data collection, monitoring, evaluation, and research evidence for evidence-based responses, and finally, stimulating robust and sustainable economic growth aimed at reducing poverty, unemployment, and inequalities. The 2021-22 annual report that the CDA board will be presenting to the committee this morning provides an analysis of the country's efforts to address substance abuse in a coordinated and coherent manner against the aforementioned strategic priorities of the National Drug Master Plan 2019-2024. The report also provides an analysis of strategic partnership the CDA has established with key local and international institutions such as the United Nations Office on Drugs and Crime, International Narcotic Control Board, the Commission on Narcotics Drugs, amongst others. These partnerships are part of our arsenal in combating to reduce illicit drug and alcohol abuse and related crimes. The growing emphasis on what works requires that we learn from each other and implement programs with a track record of success. And in closing, Chairperson, I would like to reiterate our commitment to supporting the work of the CDA board in implementing the National Drug Master Plan, as mentioned earlier. We need to form coalitions across party lines to confront the scourge of substance abuse head on. The human cost of this scourge is incalculably larger, measured not in rands and cents lost, but in the lives of young people that are shattered. With your permission, Honorable Chair, I now hand over to the Chairperson of the CDA board, Ms. Nandi Mayatula Khoza, to render the presentation. And I'm aware that the Department of Social Development team is here, and Isabella is also here. And I will have conversations with them after the presentation so that I can track and get to know what were the issues that are raised by the members of the committee. Thank you very much, Chairperson, Acting Chairperson.
Thanks a lot, Honorable Minister. Thanks a million. I didn't see your name on the system earlier when the meeting opened. You always with us whenever we call you anytime, and thank you very much. And that your team is here that will be led by the DM now to complete the presentation. Over to you, and thank you very much, Minister. If you are to leave the meeting, at least we have acknowledged you and yeah, as usually, do not disappoint us. Thank you very much. Over to you.
Good morning, Honorable Chair. I'm not too sure if you'd like me
My
to come in.
electricity has just gone off now, so yeah, I need to also save my battery by from time to time switching off my video. Okay, you may continue, ma'am. Welcome.
Yes, thank you very much, Honorable Chairperson. Let me convey our greetings on behalf of the Central Drug Authority to you as the Honorable Chair of the Select Committee on Health and Social Services. I'd like also to acknowledge the presence of the members of the committee, honorable members of the committee who are here today, the presence of the Honorable Minister, Minister Zulu, who has just given an opening remark to our presentation. And we sincerely appreciate the Honorable Minister's input and the ongoing support that we are receiving from her, the Honorable Deputy Minister as well, Ma'am Henrietta Bogopane Zulu. We also appreciate her presence, and we also appreciate the support that we receive from the DM and the work that we do with the DM on the ground with the communities. I'd like to also acknowledge and appreciate the presence of the board members of the Central Drug Authority. I'm not too sure if the chairperson would like us to introduce them. And maybe let me also acknowledge the presence of the senior government officials, the officials from Parliament, and especially from the Select Committee, and other stakeholders that would have attended the meeting. Thank you very much, Chair. Maybe let me just say that indeed we are here as the EXCO, the Executive Committee of the Central Drug Authority. I have with me the Deputy Chairperson of the board, Ms. Nomcebo Dlamini, and I have with me the other 5 members who are chairpersons of various committees. And the first one is Ma'am Nomathemba Kela, who is the chairperson of the Governance Committee in the Central Drug Authority. I then also have Ma'am Maleshohonolo Mabue, who is the chairperson of the Finance, Social and Ethics Committee of the CDA. They also take care of the affairs of members of the CDA. I then have with me the chairperson of Communications and Marketing, Ms. Darrell James, here with us. I have the chairperson of Programs and Projects with us, Ma'am Japisa Matonsi, who has joined the meeting. I then also have the chairperson of the Research Monitoring and Evaluation Committee, which is Professor Pelmos Mashabela, who is from the Ministry of the Department of Correctional Services. He is the chairperson of this research committee. So this is the complement, Honorable Chair, and I think we've also been joined by the Secretariat. So if you allow me, I will then switch off my video as well so that I can, proceed with the presentation undisturbed. We will move to the
You're welcome, Chairperson. You're welcome. You can switch off your video so we save it.
Thank you very much, Honorable Chairperson. So the purpose of the presentation is to brief the Health and Social Services Select Committee. I just want also to minimize, right. It's to brief the Health and Social Services Select Committee on the 2021-22 annual report of the Central Drug Authority. We believe it's for noting, but will be guided by the Honorable Chair. And secondly, to update the Select Committee on the implementation of the National Drug Master Plan of 2019 to 2024. And thirdly, for us as a CDA really to appreciate this invitation to the Health and Social Services Select Committee. And we also request continuous support. And as we have indicated, Honorable Chair, I think we are indeed meeting. We have been invited to this meeting for the first time. We were in November, I think it was last year, November 2022, invited by the Portfolio Committee on Social Development, and we were able also to to brief the committee on the work that we do as the Central Drug Authority. And we really appreciate these invitations and the support that we will receive from yourselves. We'll then continue to the next slide. So this presentation, Honorable Chairperson, will highlight progress on the implementation of the National Drug Master Plan 2019 to 2024 from 1st April 2021 to 31st March 2022, as contained in the 2021-22 annual report. And we will also, provide an update on the implementation of the National Drug Master Plan. I do assume again, Chair, that you and your committee have received the annual report of the Central Drug Authority, the full report. This is but a summary and an overview of that particular report. We will proceed to the next slide. Just the background, and I think the Honorable Minister alluded to this background as well, that the Central Drug Authority is a statutory body which is established in terms of the Prevention of and Treatment for Substance Abuse Act number 70 of 2008. Please pardon us the spelling, the errors there. So we are established to monitor and oversee and coordinate the implementation of the National Drug Master Plan. We are comprised of 11 independent members. In terms of the Act, we are supposed to be 13, but only 11 of us have been appointed. And we also have 17 representatives from national government departments. We are supposed to have 21 representatives from national government departments and the entities, but there are those departments that have still not, recommended representatives for appointment by the minister. So we all, the 28 members who are actively involved have special knowledge and experience in the field of substance abuse and illicit drug trafficking. And these current members of the CDA were appointed by the minister and inaugurated in May 2021. So we are about a year and a half old, somewhere there. We are still an infant, but we are hard at work. We will continue, Honorable Chair, with the next slide. So in terms of the Act number 70 of 2008, our mandate as a CDA is to coordinate national efforts in countering substance abuse and illicit drug trafficking. And we want to say, when we say substance abuse, we include all forms of drugs, but also most importantly, we include alcohol abuse. We also include tobacco abuse. We will talk to this later on. And then we are expected to submit an annual report that sets out a comprehensive description of the national efforts, the challenges, and the interventions relating to the problem of substance abuse in our country, misuse, and illicit drug trafficking. Next slide. The following are therefore the powers and functions of the CDA that are really conferred by the Act. It's to oversee and monitor the implementation of the National Drug Master Plan. And I think it's important to indicate that we as a Central Drug Authority do not necessarily implement the National Drug Master Plan, but our role is to really coordinate, to oversee and to monitor the implementation. But we will indicate at a later stage that there is one or two goals where we have a responsibility as a CDA to implement some of the outcomes, the outputs, and the indicators. We facilitate and encourage the coordination of strategic projects in our country. We facilitate the rationalization of existing resources and monitor their effective use. And in fact, our resources as a CDA are allocated from the budget of the Social Development Department, but we'll also explain later that the other 21 departments are also expected to provide resources so that they are able to implement the National Drug Master Plan. So ours is therefore to monitor the effective use of all those resources, not only financial, but also human resources. We encourage government departments and private institutions to compile plans to address substance abuse and illicit drug trafficking in line with the goals of the National Drug Master Plan. Next slide. We ensure that each Department of State has its own performance indicators. We facilitate the initiation and promotion of measures to combat the use of substance. We ensure the establishment and maintenance of information systems which will support the implementation, evaluation, and ongoing development of the National Drug Master Plan. We submit an annual report that sets out a comprehensive description of the national effort relating to the problem of substance abuse. Next slide. We ensure the development of effective strategies on prevention, early intervention, reintegration, and aftercare services. And in particular, we ensure the development of effective strategies regarding the prevention of HIV infection and other medical consequences related to substance abuse, as we will explain later, that in fact, substance abuse promotes or rather contributes to other social ills in our country, such as HIV infection through injecting of contaminated needles, etc. That's why it is important for the CDA to work with SANAC, and we have, through the Deputy Minister, been able to engage with SANAC, but also in other platforms. We advise government on policies and programs in the field of substance abuse and illicit drug trafficking. We recommend to Cabinet the review of the National Drug Master Plan every 5 years, and we have actually started only this financial year to begin to review the effectiveness of the implementation of the National Drug Master Plan in preparation for that review, which is due, I think, in 2025. We organize a biennial summit on substance abuse to enable role players in the field of substance abuse to share information. And, the last biennial summit was actually held in 2011, if I'm not mistaken. But now we have started a process to organize a biennial summit, which will happen sometime in November this year, but we will get confirmation of dates from our principals. And we are actually, before the national summit, we are engaging the provincial substance abuse forums, and the provincial are comprised by the provincial departments and various stakeholders from the community and from the province at large. So we will be engaging with the provinces, culminating to the national summit at the end of this year. We also may exercise such powers, and we perform such duties as may be determined by the minister from time to time. Let's look at the next slide. So let us take you through the National Drug Master Plan itself. We are aware that you are well conversant with this plan. We'll just try and give you a summary of it. The vision is a South Africa free of substance abuse. The mission is to embrace a balanced, integrated, and evidence-based approach to domestic drug use, misuse, and abuse, and invest in building safe communities through appropriate drug prevention and impact minimization strategies. You may have heard the minister talking about the importance of addressing crime. As you know, substance abuse contributes to crime in our community, so it has to be presented, and we must minimize the impact of it. Control the demand and supply of substance abuse and misuse, and effective control substances for therapeutic use, and the emergence of new psychoactive substances. Let's move to the next slide. The principles of the National Drug Master Plan are as follows. We must ensure that we are inclusive in our approach. We are participatory, and the minister was saying that it's important for the communities on the ground to participate in what government is doing, but also to be supported on their initiatives. It should be rights-based, promote the human rights entrenched in our constitution. When we deal with this, the issues of stigma, the issues of discrimination are things that we are currently dealing with, that it can be. It must be evidence-based because we can't continue to implement plans that are not effective. So we have to, come up with evidence-based programs, learn from other countries, learn from the communities in our country, and be able to effectively address substance abuse, alcohol abuse, and illicit drug trafficking in our country. Multi-sectoral and multilateral, I think this is the point that the minister was also emphasizing on. We can't continue to allow or to see departments working in silos. And this is what we have seen, and this is what we are discouraging. And we are encouraging departments to work together with one another, especially if departments are responsible for a particular goal, then they must definitely go to communities and work collaboratively with the other departments and with the communities as well. And it should be people-centered. It's really about people who are affected on the ground, and we can't do anything without those people. So the target population include the youth who are in school and those who are out of school who are using drugs, the children who are using drugs, because we learn that children as young as 8 years old are actually using drugs in our communities. It includes women and women who are pregnant in our society, women who are vulnerable and women who are pregnant. It includes people with disabilities. It includes occupational groups that are at risks, including those who are in arts and culture, in sports, etc. Those who are already using, we have to work with them. And it also includes key populations such as the LGBTQI, those who are in prison, and the sex workers. And the Deputy Minister does a lot of work with these populations, working together with the Central Drug Authority. The next slide. So these are the goals, and I think the Minister has actually tabulated the goals, and maybe let me not repeat what the Honorable Minister has already shared with you. So these are the 7 goals of the National Drug Master Plan, which are being implemented by the various departments and the entities of government, also by the provinces and the structures on the ground, the provincial substance, PSAF, Substance Abuse Fora, as well as the local drug action committees. So I think let's move to the next slide. So before we then report on the implementation of the National Drug Master Plan, the progress thereof, we would like to share with you the governance structure as well as the functionality of that. We have the chairperson of the Central Drug Authority and who was appointed by the minister, and the Central Drug Authority then had to appoint the deputy chairperson that I have already introduced. And the chairperson and the deputy chair are functional, they do their work, and they work together in unity and collaboratively. And however, we are expected to be supported by the secretariat. Yes, we do have a secretariat in the form of 2 social workers, as well as 2 administrators, but we have identified that there is a need for strengthening and capacity building of the secretariat for the CDA to be effective in what we are doing. And this matter has been presented to the Acting Director General and the Minister, and soon there will be a workshop to deliberate on how this can be done. The Executive Committee, as I've introduced each member to you, are functional, and we meet on a quarterly basis, and in between, as and when there is a need for us to meet. We are also supported by the Secretariat, and the same comment applies here. The portfolio committees, we have 5 portfolio committees. The Programs and Projects Committee, the Communications and Marketing Committee, the Governance Committee, the Research, Development, Monitoring and Evaluation Committee, as well as the Finance, Social and Ethics. And I did indicate that this committee also takes care of the affairs of the members of the CDA. All these committees were functional during the year under review, but the same comment on the Secretariat applies even here. And then we have the General Committee, or you may refer to it as the CDA Board, which is comprised of the 11 independent members, the 17 departments, and the Secretariat. These board is functional. We meet on a quarterly basis, and sometimes there are, special meetings that, should be organized. And we are the highest decision-making body of the CDA as the CDA board. We then have the extended general committee, which over and above the CDA members is comprised also of the PSAFs and the other key stakeholders. We meet also on a quarterly basis. We then have the 8 provincial substance abuse fora. I think we should have updated this. Okay, we will be updating this report when we look at the 2022-23 annual report, because even the 9th provincial substance abuse, I think that's just an update. Even the 9th PSAF in the Northern Cape has now been established by the MEC, but during the year under review, we only had 8 PSAFs, and then we began to really support the province towards the establishment of the Northern Cape PSAF. We then also have local drug action committees. We must say that there are very few of them which are established. Some are not even functional, and many still need to be established and be strengthened. Sometimes the LDECs are established, but they are not well supported by the municipality, and they are not well resourced by the municipality. And these are the challenges, the issues that we are dealing with on a regular basis. Let's proceed. We will elaborate on the PSAFs and the LDECs at a later stage during the course of this report. The situational analysis is as follows, that during the period under review, 2021-22, South Africa was grappling with COVID-19 challenges and the consequences thereof. For example, there were restrictions. The restrictions included the complete prohibition of tobacco sales to minimize tobacco-related risk of severe COVID-19 infection, and restriction of alcohol sales, to lower alcohol-related emergencies such as the traffic accidents that really result into deaths in healthcare facilities, and free up the space for COVID-19 emergencies. And I'm sure the Deputy Minister, Honorable Deputy Minister, will share with you later that there were challenges that they had to address immediately during the COVID-19 lockdowns. The need for alcohol, and something had to be done, etc. Also, the measures also restricted the nature and types of services that persons with substance abuse disorders, SUDs, could access, and what services could be provided by SUD service providers. And I think government departments were hard at work in as far as that is concerned. The situation in South Africa is examined against what prevails globally, as this invariably has an impact on our country and our response to the challenges of drug and other substance abuse and illicit drug trafficking. Next slide. So if you look at the global situation, we learned that in 2021, in 18 people aged 15 years to 64 years, which is about 5.6% of the world population, had used a drug, a particular form of drug, within the last 12 months, representing an increase of 26% since 2010, right? And drugs killed almost 500,000 people in 2019, in accordance with this report. And drug use disorders resulted in 18 million years of healthy lives that were lost, mostly due to opioids. Opioids, for example, the heroines that are abused by our people, and other forms. This report projects, therefore, given this situation, that by 2030, the number of people using drugs will rise by 11% around the world, and by as much as 40% in Africa alone. And this is a disturbing and concerning projection that we are also trying to analyze, and also trying to come up with more effective strategies and plans to counter this situation in our country as well. This report urges policymakers, therefore, to note that illicit drug cultivation offers no way out for impoverished communities in the long run, that the drug trade has environmental impacts, and that drug trafficking, along with associated corruption and illicit flows, undermine the rule of law and stability. That the markets for drugs are expanding to new and more vulnerable regions, and more young people are using drugs compared to previous generations. In Africa, most people being treated for drug use disorders are under the age of 35 years. And I said earlier that in fact, it goes down to 8-year-olds. 40% of countries reported cannabis as a drug associated with the greatest number of drug use disorders. Next slide. If you look now closer home in South Africa, in the absence of a national survey on substance abuse trends in the country, South Africa is dependent on SAKENDU. This is an institution in South Africa that we work with that collects data and that does research working together with the treatment centers in our country. And the World Report, whose data is sourced from participating treatment facilities across the country. During the first half of 2021, about 10,938 people were admitted. I think this is the SAKENDU report, which I said concentrates on those who are admitted by treatment centers across the 94 treatment centers. The country has 13 treatment centers that are government established and that are government run in the main by the Department of Social Development and the Department of Health. And but that number, 10,988, is compared to 9,394 in 2022. But this is just in accordance to the treatment centers. And we then are concerned with the situation whereby those who are not in the treatment centers are never counted. And therefore, one of our priorities is to have a national agenda on research throughout the country, working with the various research institutions and the national departments. So with the SAKENDU report, the 2021 report, we learned that these are the provinces who use these are the substances that are used by various provinces. And the methamphetamine, it's actually used through multiple methods, and it's mainly used in the Western Cape, in the Eastern Cape as well. And then we have alcohol, which is we drink it as South Africans, and mainly in KwaZulu-Natal. This is mostly used in KwaZulu-Natal and Central Region, and Nyaupe and heroin. The new psychoactive substances are injected by our people, and this is mostly used in Gauteng and Northern Region. But it's important to say that these substances are actually used in all the provinces, but the SAKENDU found out that mostly the high numbers of users in the treatment centers come from these provinces. Next slide. And then we have cannabis, which is smoked, mostly used in the Western Cape and Eastern Cape, but as I've indicated, throughout our country, it is used. And then we have cat, which is used orally, mostly in KwaZulu-Natal and the Central Region. We then have the polysubstance use, which is used in multiple methods in Gauteng and the Northern Region mostly. And then we have over-the-counter and prescription medicines that people just buy and use. They also have effect on their health, and there are multiple methods of use of these substances. These are mostly used in Gauteng, KwaZulu-Natal, and Western Cape. Then we have tobacco. As we all know, it is used throughout the country. It is smoked. Some of it is legal, and the other forms of tobacco are illegal and are abused, and this happens nationwide. It is therefore imperative that a national survey on trends of substance abuse should be conducted in the country to determine the trends and extent of substance or drug abuse, the need, as well as the availability, accessibility, and quality of services to respond to the need. As I've indicated, we haven't seen a national survey on the situation of substance abuse, alcohol abuse in our country, the trends thereof, and therefore it is important for that to be done. Right? Let's move to the next slide. South Africa has the 6th highest per person alcohol intake in the world and the highest alcohol consumption rate in Africa. We consume 11 liters per capita. And this is costly to the country. I think it costs the country 12% of our annual GDP. Alcohol abuse is the 5th largest contributor to the years of lives that are lost, with alcohol-related illnesses disproportionately affecting socioeconomic groups. And there's a need for purposeful targeting of markets in low and middle income countries, particularly the young people. There's also, the research shows an association between alcohol market exposure and positive attitudes towards alcohol, earlier drinking initiation, and high levels of consumption. There is a link between mental health and alcohol abuse, such as depression, risk of suicide, anxiety, low self-esteem, psychological distress, post-traumatic stress disorders, etc., mental health as a whole. And then there's social engagements, which tend to center around drinking. When we go and watch sports, you know, we drink as South Africans. And when we go, you know, to occasions, we drink, etc. So sometimes we overdrink, and that's where the problem is. Alcohol abuse contributes to gender-based violence, as the minister was saying earlier on, to HIV/AIDS and other social and health conditions in the South African society. Next slide. So I think the minister also alluded to the fact that we do, during the year under review, we did interact with various international stakeholders, including the Commission on Narcotics Drugs. We were actually invited to a session. It was a 64th session or 65th session of the CND, which happens in Vienna every year. We also interact very closely with the United Nations Office on Drugs and Crime. We interact with the World Health Organization, even though the interaction has to be strengthened there. We interact with the African Union. Again, we are also strengthening that interaction. The Colombo Plan, we also interact with the countries of BRICS on formal anti-drug issues. There is a committee to that effect. Next slide. We also interact and engage with national stakeholders such as SANCA, Medical Research Council, the South African Network of People Who Use Drugs, because they say nothing about them for them, so that they must be included in the plans, in the implementation of the National Drug Master Plan. We interact also with SAKENDU, as I've already indicated. They help us with data collection and research work. We interact with SALGA, to encourage SALGA to ensure that all the municipalities do establish the local drug action committees, and where appropriate, the district local drug action committees. And in fact, one of those at the district level has been established by the Deputy Minister, and I hope that later on she may talk to that. And then we interact with SANAC. As I've indicated, there's a relationship between substance abuse and HIV. And if we don't work together, we can never reduce HIV infections in our country. We then also work with the other international organizations that are listed there, the ICUDDR, the ISUP South Africa, the INHSU. We also interact in terms of the webinars and training programs, but we engage really on the implementation of the National Drug Master Plan. Next slide. So in terms of the performance management and monitoring, because this is our role, we want to state that the national departments and entities, as well as the PSAPs, submit annual reports to the CDA on the implementation of their sector drug master plans, which should be aligned to the National Drug Master Plan. So ideally, these reports should be read against the sector drug master plans. The Act speaks about the mini drug master plans of each and every sector, but we prefer to refer to them as sector drug master plans. We should have been compiled and costed, but only 4 of the national departments have the drug master plans, and these are the Department of Social Development, the Department of Health, the South African Police Service, the Department of Justice and Correctional Services, who are reviewing their drug master plan. The rest of the 21 departments that have a duty to implement the National Drug Master Plan and to have their sector drug master plan do not have these plans. And this is one of the areas that we have requested the minister to assist us with, and the ministers together with the deputy minister, we presume they will be assisting us to ensure that other ministers ensure that those other departments that are not represented in the CDA, that don't even have the drug master plans, do so. Because if we don't do this, then implementation of the National Drug Master Plan will be weak. The CDA is therefore focusing on assisting departments to craft their sector drug master plans and to integrate the National Drug Master Plan goals and deliverables into their strategic plans and the annual performance plans with clear targets and KPIs, because we believe that when this is the case, then there will be a budget. But if we don't have any indicators in the APPs of departments and agencies and provinces, then we won't see effective implementation of the National Drug Master Plan. The departments are complemented, especially those departments who are represented in the CDA, who are also submitting their annual reports. They are complemented, and there are those, even though they are very few, who submit the 6 monthly reports, that is the biannual reports, so that actually assists us to track the implementation of the National Drug Master Plan and to make it easy for us to put together an annual report to be submitted to the minister and to Parliament. However, the timelines for submission of the reports were generally not adhered to. It's something that the departments have been requested to improve together with the PSAFs. The departments are indeed attempting to work together in clusters. I did say earlier on that when we arrived, we observed a situation whereby departments and entities were working in silos. But since we have spoken about integration, multi-sectoral approach, we see now an attempt of departments working as clusters, working together. When they engage with communities, we have seen especially the social cluster and the security cluster going together with other departments, but we need to see more of that so that there should be effective implementation and integrated implementation of the National Drug Master Plan. Many departments, however, do not appear to understand the National Drug Master Plan and the meaningful role that they are expected to play. And that's why we said earlier on that we together with the social development, we are actually conducting the provincial capacity building training programs to ensure that even with the national departments, I think we've done that, to ensure that everybody understands the National Drug Master Plan and what is expected of each of these role players and key stakeholders. Next slide. So we now zoom into the PSAFs, the Provincial Substance Abuse Forum, and where we are in terms of the implementation of the National Drug Master Plan, in terms of the governance structures in those provinces, in terms of the conveners in those provinces, as well as in terms of whether or not there are financial resources and human resources that are allocated to the Provincial Substance Abuse Forum. If you look at Eastern Cape, for example, yes, when they report to the CDA or biannually as well as annually, they do use the National Drug Master Plan template. And we are speaking about the 2019-2024 National Drug Master Plan. And then Eastern Cape does report on 4 goals. Remember, we said there are 7 goals, but they only report on 4 goals, and we have encouraged them to also include the other 3 goals, implement them because they're also essential in their communities, and report on them. In terms of the governance structures in Eastern Cape, yes, they do have a PSAF, they have a chairperson and the PSAF members, and they are functional and they report regularly. And then they have the convener, is the DSD, is the convener of the PSAFs in all the provinces. And in terms of resources, Eastern Cape reported to us that they are not they are not allocated resources, especially financial resources for them to implement their drug master plan or the National Drug Master Plan. And in Gauteng, yes, they report according to the template. They only report on 5 of the 7 goals. There is no interim chairperson, and we're talking about the year under review up to March 2022. There has been some improvement after that, and we will report on that when we report to the minister on the 2022-23 annual report. And yes, the DSD convenes the PSAF in Gauteng, and they also reported to us that they do not have resources, no resources allocated specifically to them. But we believe that the DSD has a budget. It implements, spends the budget on their program, but the PSAF say they also need a budget to be able to implement the National Drug Master Plan. KwaZulu-Natal, yes, they report according to the template, and they report only on 5 instead of 7 goals. In KwaZulu-Natal, the chairperson of the PSAF is the MEC herself, and but during the year under review, there were no deputy chairpersons, and the CDA assisted the KwaZulu-Natal to fully establish the PSAF during that year. And now we do have the deputy chairperson. That's just an update, right? DSD convenes them, and they did indicate that they do get an allocation of resources so that they can do their work. Free State does not report in accordance with the National Drug Master Plan, and they report only on 4 goals of the National Drug Master Plan. And yes, their PSAF is operational, it has been established, and the DSD helps them to convene, but they also do not get resources for them to implement their drug master plans. Limpopo reports according to the template, and they only report on 4 goals instead of 7 goals. The governance structure, the PSAF had to be relaunched. I think it was relaunched only during this year. During 2021-22, the PSAF had not been launched, but there has been progress since then. DSD is convening them, and they also indicated that there was no allocation of resources for them to do the work. Mpumalanga, yes, reports according to the template. They report only on 5 goals instead of 7. And yes, the PSAF is in place there and it's functional. And DSD is assisting them to convene and is supporting them. And that yes, DSD does allocate a budget and human resources for them to implement the drug master plan. Northwest reports according to the template, but they report only on 3 goals, and they report on 3 goals. And yes, there is a PSAF there, and yes, the DSD is convening them, but they do not get allocated in terms of the finances and the human resources. Northern Cape, at the time of reporting up to March 2022, they were not reporting according to the template, and they were only reporting on 1 goal, and there was no structure during the year under review, but the DSD was convening them, and hence to date, as an update, there is a PSAF, and it's supported by the MEC, but they have not been allocated resources for them to do the work. Western Cape, they do report according to the template of the National Drug Master Plan, but they only report on 4 goals instead of 5 goals, instead of 7 goals. And they have a governance structure. They do have a PSAF. DSD does convene them, but they also stated that they do not get allocated resources for them to do the work. Next slide. In fact, from what we have observed, it looks like, you know, in the main, there's one main person who is doing this work. And she did say that it's a lot of work for her. So she does need, you know, the chairperson of the PSAF in Western Cape, she does need really support in terms of human resources and in terms of the finances. It's important also to indicate, or maybe let me not do that now, I'll do it later. The reports from the PSAFs in terms of the implementation of the National Drug Master Plan are such that most of the PSAFs are focused on implementing goal number 1, interventions, mainly prevention awareness, but they're not reporting on harm reduction interventions. Goal number 1, remember, it's about demand reduction through prevention programs and harm reduction programs. And they also report on goal number 2, which is the second focus of all the PSAFs, reflecting that security enforcement is seen as low-hanging fruit, but I think there's a lot of work that is done by SAPs or the security clusters in the provinces, which require minimal change of focus from the National Drug Master Plan. So what we are saying here is that there must be a change. Previously, we've had a 2013-2017 National Drug Master Plan, but that was drastically changed. And as you have heard, there are principles that guide the 2019-2024 National Drug Master Plan. But we have observed that in some cases in the province, they tend to, to implement the 2013-2017. But we are assisting them to change through the capacity building training programs that we spoke about earlier on. The PSAFs also appeared to be operating in accordance, or I've indicated that in accordance with the previous National Drug Master Plan, but as I've indicated, we are capacitating them to implement the current 2019-24 National Drug Master Plan. Okay, and they need to implement that in accordance with the monitoring and evaluation framework that we have as the CDA, but we still need to populate it in terms of indicators and targets, and we are working on that. There's legal evidence on collaboration between departments in the provinces and between departments and civil society organizations in the implementation of the National Drug Master Plan. And this is the silo mentality that we spoke about. But as we engage with the PSAFs, as we engage with the provinces, now that also will be doing the provincial dialogues, we are going to emphasize on the importance of collaboration and integration in terms of approach. A real challenge is that the departments are not engaging with the PSAFs, which cannot function optimally without the departments, as cited in the Act number 70 of 2008. The PSAFs appear to be sustained by social development in the main and substance abuse experts in the provinces. We still need to ensure that even other departments in the provinces really take responsibility to implement the National Drug Master Plan. Most PSAFs again indicated a need for human resource capacitation, which was also reflected in the 2020-2021 annual report. Next slide. So this is really the Honorable Chair and members, the detail of the implementation of the National Drug Master Plan as at the end of 2021-22, but also the implementation of the Ekurhuleni National Conference, which was held in 2029, which was convened by the Department of Social Development in partnership with the CDA. So we report on the 7 goals as to what achievements are there, what challenges are there, and what recommendations has the CDA proposed to the national departments as well as to the PSAFs. So on the first goal, as we've indicated, I think a lot of departments are really implementing the prevention methods. It could include, engagement of the school learners, engagement of the employees, of the crime offenders, of the parents, of the students in institutions of higher learning, but they're also engaged in early intervention over and above prevention and awareness raising strategies and campaigns. And maybe I won't really talk to the details, but because we do give numbers that are reported against the targets that are set by the various departments. But we then recommend on this work that the departments need to conduct prevention and awareness campaigns in collaboration with other departments to rationalize the use of resources and so that they can be impact on the ground. The National Policy on Prevention of and Treatment of Substance Abuse Use Disorders has been developed by the Department of Social Development, and they have consulted various stakeholders, including the national departments, etc. And this policy is being developed so that it can assist in terms of reviewing the Act number 70 of 2008. Because now that we're talking about a scientific and evidence-based approach, multi-sectoral approach, there's then be a need for social development, who's the custodian and the champion of the Act, to then review the Act. The CDA has also been consulted in terms of this particular policy. Next slide. So on treatment and harm reduction, the Departments of Social Development, Health and Correctional Services continue with the provisions of treatment to users in the public treatment centers and ensuring adherence to the norms and standards, the service standards themselves. The Department of our observation is that also the Department of Health has begun to look at the evidence-based harm reduction programs that are spelled out in the National Drug Master Plan, which include the opioid substitution treatment. And the Health Department has developed a comprehensive and costed plan, as well as the clinical guidelines for the treatment of people with substance use disorders, and they are supported by the World Health Organization. We have recommended to these departments that they need to upscale and fund more of these harm reduction programs, not only OTP, but other harm reduction programs as spelled out in the National Drug Master Plan throughout the country in order to reduce harm. Next slide. Still on goal number 1, Social Development Department monitors the implementation of the strategy on reintegration and aftercare programs for the recovering users. And they provide numbers of recovering users that gained access to aftercare and reintegration services and after treatment. But we must emphasize that as CDA would like to see this work being upscaled in terms of aftercare, so that even though we know that substance abuse, drug abuse, alcohol abuse is a chronic relapsing disease, but we can be able, through the scientific and evidence-based programs, we can be able to, to reduce the impact of relapsing. So there is a need to upscale aftercare programs, to upscale skills development programs, employment of the users once they've recovered, as well as support them in terms of entrepreneurship programs for the recovering users. You will see that when we report on goal number 7, which is about this particular recommendation, very little is reported to the CDA. So we even wonder if departments and the PSAFs are actually doing this work. Unless we have reports, we can never know if the users are assisted once they've recovered through various programs to address poverty and unemployment, as well as inequality. The NGOs were also funded to programs and were monitored for compliance with service standards. And in the main, they're funded by the Department of Social Development as well as the Department of Health. And as such, they have a database of the funded organization. We have, however, recommended as the CDA that there is a need to monitor the unfunded treatment centers because there are many treatment centers that are unfunded. So it's very important to know what is going on. Operations to monitor needs to be in collaboration with the Security Cluster Department so that we inculcate the approach, the multi-sectoral approach of doing things. Next slide. We now move to goal number 2. In terms of the achievement, this goal is driven by the social cluster, which is SAPS, Justice and Constitutional Development, NPA, etc. So they reported that they've published the Cannabis for Private Purpose Bill number 19 of 2020 in the government gazette, and the public hearings are being held, and the bill is now before the Portfolio Committee for a close by close reading. So we are happy as the CDA in as far as that progress is concerned. And the National Prosecuting Authority collaborated with SAPS, including the Directorate of Priority Crime Investigations, to mitigate the supply of drugs in an effective manner. And we as the CDA must monitor the effectiveness of these collaborations and supply demand. But we do appreciate the fact that the security cluster is one of those clusters that are really, really working together and not in silos. Enhanced the processing of forensic evidence of drug-related investigations, reduced identified drug syndicates, dealt with organized crime threat, enhanced intelligence and effectiveness of law enforcement. So we as the CDA will continue to monitor this situation. Next slide. Still on goal number 2, there has been strengthening of partnerships in monitoring the chemical companies, receiving of import notification on online system by the Security Cluster Department. They have also addressed the illegal trade of liquor and other drugs. They have conducted liquor operations. They have undertook border post policing actions, but we must say that as a CDA, we are very concerned about the illicit drug trafficking across the border posts, and that really needs to be seriously addressed by the security cluster, including the Home Affairs Department. They have used or enhanced movement and movement control systems on persons and vehicles. They've undertaken actions targeted at drug trafficking in land ports, seaports, and airports. So as a CDA, our role really needs to be strengthened in terms of measuring the effectiveness of these programs and the impact of the partnerships to see where we are as a country in terms of countering the drug illicit trafficking. To mitigate the supply of drugs and liquor, the South African Revenue, SARS, undertook 913 risk analysis and narcotic seizures at airports worth 409 million and 898 at 16 airports worth 31.4 million. I think a lot of work is being done here, but more work can be done. And we will be undertaking oversight visits at the airports to monitor this situation and the effectiveness thereof. Next slide. Goal number 3, you can see that it's very scanty, and it's led by the Department of Health and SAPRA, and they have implemented the controlled licensing and permit processes, but we will be monitoring the implementation of the whole goal because this is not all that needs to be implemented. Goal number 4, there has been detection of 7 cases of new psychotropic, psychoactive substances, because this is about identifying and controlling the new psychoactive substances. This is being done. And the CDA needs to encourage all other provinces to carry out activities under this goal and report back, because on a regular basis, we hear about a new drug, a new designer drug that has been concocted by our communities. And we need to know these drugs so that we can be able to know how we address them. The departments under this goal have monitored the trends in the composition, production, distribution of new psychoactive substances, the amphetamine type stimulants, and other chemicals used to illicit drugs, and they have arrested 274 drug dealers during the year under review. And the CDA will also continue to monitor the trends of the NPS. And they've trained the government officials on how to identify the NPS in KwaZulu-Natal. Dagga, cocaine, crystal meth, heroin, nyaupe, and other chemicals were confiscated in Gauteng and in Mpumalanga. And we still need to get reports from the other provinces as well who are not reporting on this. Let's move to the next slide. Goal number 5 is led by the Central Drug Authority and as well as the Social Development Department. And we, as part of capacitating the CDA, the Chief Director of Substance Abuse and Social Crime Directorate, Ms. Mahangwe, has been deployed to assist the CDA. And I've indicated earlier that we have 2 members of the Secretariat, the 2 social workers, and we also have the 2 administrators who are supporting us in terms of administrative work. But we've indicated that the support is limited but the Secretariat themselves have indicated that they really need to be strengthened. Their capacity needs to be strengthened. In fact, they were saying that there's a need for review of their work and to ensure that CDA is effectively supported. We have requested the Minister to assist in ensuring that there is an employment of a director as stipulated in the Act of 2008, and the Acting Director General is looking at this situation, and the Minister is also looking at this situation for the employment of a director. We have, as the CDA, looked at you know, the grading of the job, etc. That has been done, and we have interacted with the social development, because we definitely need a director. Without a director, really, it's very difficult. The work that should be done by the director is actually done by the members of the CDA, which shouldn't be the case because we are the governance structure. CDA successfully held meetings with departments and entities towards the appointment of representatives. We have been writing too many letters to the departments that are not represented, and we have seen some improvement, but we still have some few departments that still need to appoint the representatives. And we still need to see more departments and the PSAFs developing their own drug master plans. We also, as the CDA, delegated each independent member of the CDA to the provinces to really support each of the PSAFs in our country, to participate in the meetings and actually to assist them in guiding them on the implementation of the National Drug Master Plan. So the independent members are deployed in the provinces, but they're also deployed in the departments also to ensure that the departments have their drug master plans and that they report regularly on the implementation of the drug master plans. We undertook a strategic planning session jointly with the government departments, and we developed the medium-term performance plan, but from that, we then also developed the 2022-23 annual performance plan. And this is the APP that we have been implementing as the CDA. And yeah, let's move to the next slide. Still on goal number 5, we have involved strategic stakeholders who are not necessarily members of the CDA to review the 3rd CDA annual report, which the 3rd, 4th CDA had actually prepared, as we only were appointed in 2021, April. We will continue to involve the stakeholders in planning and in reviewing the implementation of the National Drug Master Plan. As CDA, we have been encouraging the government departments and the entities to allocate budgets for the rollout of the National Drug Master Plan, and we will continue to do that. We have not had direct contact and engagement with the World Health Organization and African Union, but we started immediately after. We then made a conscious decision to reach out to these organizations, and we will be able to report with the 2022-23 annual report on what work has been done with World Health Organization and African Union. SAHPRA has added 20 substances to Schedule 7 of the Schedules to the Medicines Act, in line with the recommendations of the 63rd meeting of the Commission on Narcotic Drugs, because this is their responsibility. Still on goal number 5, I think I've reported on the Provincial Substance Abuse Forum. Let me not repeat what I said. I've also reported on the local drug action committees, and we'll give a detail at a later stage. On goal number 6, the Department of Health has a contract with the South African Medical Research Council for SAKENDU to collect data on drug use. I think I've spoken about this, and the need, however, for the national survey to be undertaken. 4 quarterly reports were received, which highlighted a significant decrease, 51%, in the number of children arrested for possession and or use of drugs. This is the report that we have received. But much more work really still needs to be done in as far as this goal, and the Committee on Research is hard at work to do this. Goal number 7. Oh, sorry, before number 7, just to reiterate that there is no national research agenda. And therefore, the CDA is collaborating with research institutions to undertake the National Prevalence Survey on drugs and alcohol. We've actually been informed that it would cost about 10 to 12 million, and the CDA doesn't have that amount of money. We will talk to that later on. Only one province reported that they've developed a database, as we've indicated earlier on. And under goal number 7, as you can see, it's very scanty. In fact, most of the departments that are supposed to implement the National Drug Master Plan on addressing poverty, unemployment through economic development, skills development, etc., are not participating in the CDA. And therefore, we've written many letters, but we've now requested the acting Director General to escalate this matter to the minister, and the minister will escalate it to the other ministers. Okay, because there hasn't been any reporting from the national departments on this very important goal. So we are dealing with this particular situation because it can be, given the high levels of poverty and unemployment in our country, inequalities, and the fact that some of the users of drugs, some of those who are abusing alcohol, are really driven by these challenges, even though we know that other users come from affluent families as well. The 7 provinces reported that they carried out activities aimed at reducing poverty, unemployment, and inequalities, especially among substance users who are recovering, including their families. And we have requested all provinces really to execute this particular program to address the root causes of drug use and alcohol abuse in our country, and we'll be closely monitoring this situation. Next slide. In terms of the finances of the CDA, we are funded through the National Social Development Directorate of Substance Abuse and Social Crime. And members include national departments that should allocate some of their budgets to combating substance use and abuse in the country. So we're basically saying that even the national departments are also expected to have budgets for substance abuse and illicit drug trafficking in the country. It can't just be a budget from one department. The CDA translated the strategic plan. We now have an annual performance plan. We actually had an annual performance plan for the year 2022-23, and we've also recently developed an annual performance plan for 2023-24. So we are starting now to implement that APP. The current positioning of CDA compromises sound financial planning and expenditure monitoring principles. We have discussed this with the minister and the acting Director General to say that the fact that we as a CDA are actually located within the social development department, it becomes very difficult for other departments to take the CDA seriously and implement National Drug Master Plan. And that's why we are saying that we need to relook at the positioning of the CDA. In fact, we were informed that there were some decisions of the cabinet in the past, I think it was in 2019, that still needs to be, to be addressed, because it really needs to be understood that the CDA is not a department, even though it's funded by a department, but the CDA is really an overarching body of the country that is responsible for all the 21 departments to ensure that they implement the National Drug Master Plan, but also oversee the work of the provinces, but also the work of the communities, the community-based structures, and everyone else, the key stakeholders as well. So hence we are saying the positioning really needs to be relooked at so that the CDA is an independent, totally independent body, and that we are able to effectively monitor the implementation of the National Drug Master Plan. The DSD provides and mostly controls the human and financial resources allocated to the CDA from the voted budget. And we have also indicated as a CDA that we really need to have control of the budget to see where the money is going, because according to the Act, we have to monitor the effective use of resources. for, to counter substance abuse in our country. So we need more control of the budget of the CDA. We have discussed this, and hence I said there would be a workshop with the Acting Director General and the senior officials to address this matter. The majority of the budget caters for operational costs rather than being based on the outputs related to the implementation of the National Drug Master Plan. I think that workshop that I'm alluding to will address these particular situations that we find ourselves in. The current budget is incongruent with the CDA's national oversight role. In fact, the budget that we found when we were appointed is a budget that was based on the previous CDA, and whereas there was not even a business plan of the previous CDA, we did not find any annual performance plan. So it was just a budget, really. We don't know what it was based on, but we believe that it really needs to be reviewed in accordance with the plans of the current CDA. Next slide. So this is the expenditure report of the CDA as at the end. Okay, I did ask for a report as at the end of March 2022, but I see that we still have a report as at the end of January, a secretariat, which is a problem. So as at the end of January, as per this slide, we spent about 83.6%, but we continue to spend in February up to March 2022. The overall budget was 6.89 million rands of the CDA. And from that, the 2.32 million is for the compensation of the employees. I spoke about the 2 secretariat members as well as the 2 administrators. That is for their salaries. And then for goods and services, for the implementation of the national, or rather to monitor, to coordinate, and to oversee the implementation of the National Drug Master Plan, the CDA has 4.48 million rands on the goods and services. So yeah, let's move to the next slide. We apologize as Select Committee for not giving you the most recent budget. I asked for it. I do not know what really happened. Perhaps the Secretariat can assist today. In terms of evaluation, we're moving towards conclusion of our presentation. Our evaluation is such that the CDA mandate is not to be an implementation agent of the National Drug Master Plan, but to direct, to coordinate, to control, to monitor, and to evaluate the programs and activities of its implementation by the stakeholders, the national departments, the provincial, as well as local government. This is a narrative evaluation of these reports, which were covered in more detail in the report, that the departments and provinces have not shifted their approach to align to the National Drug Master Plan. Not all of them, but we've identified few of such national departments and few of such provinces who must now really focus on the 2019-24 implementation of the National Drug Master Plan. The strong focus, again, is on activities aimed at reducing social ills and improving the well-being of children, families, and communities, which is commendable, but contributes to a single outcome, which is not sustainable. So there's a need for the implementers of the National Drug Master Plan to really focus on all the outcomes, or all the 7 goals and the indicators. Reporting by departments in the security cluster reveals that the approach taken remains punitive, and we have been really discussing the new approach, which is not punitive, and the minister spoke about the public health approach, that the users, instead of being arrested for possession of small amounts of drugs, they should be assisted, through the treatment, harm reduction processes, aftercare programs, and reintegration back into society. But of course, I mean, if communities are complaining about criminality arising from such, then the law enforcement can really do their work. The departments do not seem to be continuously working towards meeting the National Drug Master Plan goals. Their efforts are incidental, so we are really looking into this situation, and going forward, we'll ensure that this happens. Departments continue to work in silos, except for the departments within the security cluster, which seem to be working together to a limited extent, but I did indicate that even social cluster is beginning to work using the multi-sectoral approach. And we need to see more of that happening going forward. Most departments do not have departmental drug master plans. We did say that only 4 national departments have drug master plans, which means that about 17 of them, or rather 16 of them, do not have the drug master plans, which is a big challenge for us as the CDA. How do we monitor? How do we coordinate the implementation if there are no drug master plans of the sectors? The departments and provinces are not working in tandem, as evidenced by the departments not engaging in the PSAPs. This is at the provincial level. I think they see this work as a social development work and a health work. The other departments like economic development, agricultural development, etc., those who are actually doing work in terms of skills development, employment creation, etc., are really not assisting the provinces or the PSAPs. National departments, or provincial departments rather, of social development have kept the PSAPs alive and somewhat functional, albeit with few resources to sustain their activities and to function as independent substructures of the CDA. But we want to see more other departments at the provincial level assisting the PSAPs with resources that they need. Next slide. So the recommendations in the 2021-22 annual report is that, number 1, there is a need to resuscitate the interministerial committee to combat substance abuse, not combat, but counter. Again, we are working on our language. Now that we have begun to interact with the international organizations, we are sensitized on the correct language that needs to be used. We are no longer in war against drug abuse, but we are countering, addressing drug abuse, alcohol abuse in a multi-sectoral approach and using evidence-based programs. And this IMC was established in 2010, so we're here, but subsequently ceased to function. It gave effect to the multi-sectoral approach proposed in the Act and comprised the Minister of Social Development as the convener and the other ministers of key departments that are mentioned in the National Drug Master Plan. So we've had a discussion with the Acting Director General and the Minister in as far as this is concerned, and there is an appetite indeed. I think they did say that they will be supporting the resuscitation of the IMC so that the country has a political buy-in in as far as addressing this serious problem. Recommendation number 2 is to reinforce the CDA Secretariat by employing an executive director as per Section 55 of the Act. And I did allude to the fact that there's going to be a workshop very soon with the Acting Director General, who has been tasked by the Minister to look at all the challenges of the CDA and work with us to address this, because we are really limping in as far as the Secretariat is concerned. We actually do work that we are not supposed to be doing as members of the CDA because of lack of capacity. Strengthening stakeholder relations through the CDA. We will continue with the hosting of 2 national stakeholder forums per year to encourage continuous engagement around the strategies and the reporting, and also establishing an international annual think tank to include all stakeholders and benchmark program implementation, strengthen M&E and global compliance standards. Number 4 is to develop a national research agenda for substance abuse. I think I've spoken at length in as far as this is concerned. Without data, without any national survey, how can we know how we are doing as a country in terms of the trends of drug and alcohol abuse, as well as illicit drug trafficking in the country? And the 5th recommendation is to improve monitoring and evaluation. We are to develop as a CDA the tools to manage the submission of reports by departments and provinces, as well as the internal governance systems needed to implement oversight and support as per the National Drug Master Plan. Currently, I think there's a lot really that needs to be improved. As we indicated, not all departments are submitting, but also even the system that we are using needs to be improved. Next slide. Honorable Chair, you also requested us to update you on the implementation of the National Drug Master Plan. We've spoken about the annual report at the end of March 2022. Between March 2022 and to date, we wish to indicate that The Minister of Social Development has tabled the annual reports, I think all of them, and the CDA will therefore be compiling the 2022-23 annual report. Like now we are starting to compile that particular report. And these reports detail the progress on the implementation of the National Drug Master Plan 2019 to 2024 since its launch in June 2020. Next slide. In terms of the PSAPs, just an update after March 2022, just to update you, Honorable Chair and committee members, as to what is happening, because there has been an improvement because of the interventions of the CDA and the interventions of the lead departments. In Gauteng, yes, the PSAF is in place. There is an interim chairperson who then needs to be formally appointed by the MEC, because all PSAFs are established by the MEC. And the PSAF in Gauteng is functional. The departments that are participating are only, is it 17 departments that are participating in Gauteng. And yes, there is a drug master plan in place in Gauteng. In Eastern Cape, the PSAF is in place and it's functional. There are only 7 departments that are participating, but they do not have a drug master plan. In Western Cape, the PSAF is in place and it's functional, and but we did not receive information on the number of departments that are participating in the Eastern Cape it's 7, Western Cape there is no information on the number of departments that are participating, and there is no drug master plan. Northern Cape, as I indicated earlier on, during that year under review 2021-22, there was no PSAF. Now it has been established by the minister and it's functional. In fact, the CDA visited it together with the acting director general a month ago, and we met with the MEC, and the MEC really committed herself to support the Northern Cape PSAF, and also committed to find the resources, because she kept on saying we need the resources, and there are not adequate resources even within the DSD department for this particular work. The province will provide a full report in Q4. They don't have a drug master plan. Those who are deployed in this province will assist the province to, in fact, other provinces as well. CDA representatives will assist all the provinces that don't have the drug master plans to do so. The Free State has a PSAF that's functional. Only 8 departments are involved in that PSAF. They do have a drug master plan. The Northwest has a PSAF that's functional. 12 departments are participating, but they don't have a drug master plan. The Mpumalanga has a functional PSAF. Only 7 departments are participating. They don't have a drug master plan, but I think the last time we got a report, they actually had a draft drug master plan, which are supposed to go through the processes to the MEC and to the cabinet for approval. Limpopo has a functional PSAF, and 9 departments are participating. They now have a drug master plan. They were actually assisted by the CDA members and the secretariat to put together a drug master plan, and it has now been adopted by the cabinet in the province. KwaZulu-Natal has a functional PSAF, but we don't know how many departments are participating in that PSAF. They also don't have a drug master plan. The CDA members that are deployed in KwaZulu-Natal are also assisting that province to put together a drug master plan. There has been a workshop in that regard. Next slide. In terms of the local drug action committees in the provinces, in Gauteng, we have 9 municipalities of the 14 municipalities that have LDEX. We have 9 local municipalities, 4 have the LDEX, and 4 have been formally appointed by the mayor, because the LDEC has to be appointed by the mayor. If there's an LDEC in a province that has not been signed off by the mayor, and if members do not have a letter of appointment from the mayor, then those are not LDECs, but they are community-based structures that are doing this work, and they appreciate to do that, but they can't be referred to as LDECs. Number of LDECs that are functional, all the 4 that have been appointed by the mayor are functional, right? And in Eastern Cape, there are 33 municipalities, and 11 of those have LDECs. 13 of those formally appointed by the mayor, and 8 of those are functional. Western Cape, there are 25 municipalities, 18 local drug action committees that were established, and 18 were formally appointed by the mayor, and 18 are actually functional. In Northern Cape, there are 26 municipalities, only 1 LDEC has been formed during the as current status. 1 has been formed, and but has not been formally appointed by the mayor. We need to, as we engage with the Northern Cape, to ensure that happens. That 1 that has been established is functional. In the Free State, there are 19 municipalities, 11 are established, 11 are appointed by the mayor, and 11 are functional. In the Northwest, 18 municipalities, only 4 are established, 4 are appointed by the mayor, and they are functional. In Mpumalanga, 17 municipalities, we just need to double check on that, because we can't have 18 LDECs and 17 municipalities. We need to double check whether the 18th one is a district one or not. 9 have been formally appointed by the mayor, and 12 are functional. In Limpopo, 22 municipalities, of these, only 7 have LDECs, which are functional, which are appointed by the mayor. In KwaZulu-Natal, it's 44 municipalities, and 51 LDECs have been appointed. The provinces reported 51 LDECs in their report. This means that there is probably inclusion of the districts as well. I think we'll just double check on that. But these 51 LDECs have not been appointed by the mayor. Even though they are not appointed by the mayor, 23 of them are functional. So the total number of local and metro municipalities, as you know, I think it's we have about 200, I think I stand to be corrected, 287 in total municipalities, including the districts. The Act speaks about LDECs, it doesn't speak about the districts, but as I've indicated earlier, there is an initiative from the Department of Social Development to establish, led by the Deputy Minister, to establish the district drug action committees. So the 213 municipalities exclude the 44 district municipalities, and in total, there's 125 LDECs that are established in the country. Of those, 66 have been appointed by the mayor, and 88 are functional, which means even those that are not appointed by the mayor are functional. But I did explain the challenge that really we can't refer to a structure that has not been appointed by the mayor as an LDEC up until it is appointed by the mayor formally. But like I said, we don't de-establish them. We allow them because they're doing important work in the community. Next slide. Oh, here's the number, sorry. There are 257 municipalities in South Africa, comprising of 8 metropolitan municipalities, 44 districts, 205 local municipalities. However, the establishment of LDECs in metros and districts is not feasible because of the size. I think this is an opinion, but we should actually be driven by the metros and the districts themselves. We have recommended that the legislation be reviewed to provide regional and local municipalities. By regional, I suppose it's the districts and the metros, and then the local municipalities are well known. The CDA has been focusing on the establishment of LDECs in collaboration with SALGA. We have presented at SALGA conferences in 8 provinces because SALGA, immediately when the municipalities they were elected, the local governments were elected, SALGA engaged on the conferences, and then we requested to be part of those as CDA, and this is where we're encouraging the importance of the mayors establishing the LDECs, but also supporting those LDECs in terms of human resources and finances. And next slide. I think, okay, just an update. I think I've spoken about the Northern Cape. Let me not repeat. Provinces and some departments implemented, I've spoken about the implementation of the National Drug Master Plan, and that not all of them have drug master plans. The annual report on the implementation of the National Drug Master Plan for 2022-23 will be submitted to the Minister by the 30th of August, and we'll be happy to be invited again by the Select Committee thereafter to make a presentation to see if there is progress on the work that we do, but also to look at the challenges and address those challenges. The DSD through the CDA has capacitated the Provincial Substance Abuse Forum to enable them to implement the plan.
Chairperson, mind the time. I think you have gone on the other side of the time allocated for you. If you could just,
conclude.
Yes,
Thank you.
Conclude. Yeah.
Thank you, Honorable Chair. Just move quickly. Let's see what was next. It's basically the way forward as to what needs to be done, Honorable Chair. I think the members have seen the actual report, but just to say that indeed, as I've indicated, we are engaging with the national and international stakeholders. We are engaging with the communities through the provincial dialogues in preparation for the national summit. The last slide. On recommendations, but we note all the problems that are happening with regard to substance abuse in various provinces. I'm sure you've noted the Enyobeni incident, the incidences in Gauteng, in Westbury, in Eldorado Park. We've been engaging even with the Premier, the MECs, and the communities on this situation, KwaZulu-Natal, and the other upheavals nationwide, so that together we can address the sketch and ensure that there are no gunshots and there are no young people who continue to be killed by the drug lords. Recommendations? We recommend, therefore, Honorable Chair and Committee, for you to note the annual reports of the CDA, but also to note the update on the implementation of the National Drug Master Plan, and we also provide to plead for provision of continuous support to the CDA to address the challenges, noting that we are already getting some support from the Minister, the Deputy Minister, the ADG, and the senior officials of the department and other departments. Thank you very much, Honorable Chair. I will hand over back to the Honorable Chair. Thank you.
Oh, I was talking and my mic was muted. So, now saying thanks for the briefing. It's yeah, but at the same time it shows that we have a very long way to go. And the fact that we don't have a national research program for this really boggles the mind. The minister said in opening remarks that there's an increase of drug abuse all over the world, and our country is not an exception. And here in South Africa, we have some new designer drugs that are not anywhere in the world. I think Nyaobe is only produced or whatever, consumed in South Africa. And our fight against drug abuse, alcohol, tobacco, and dagga, and all other substances, it's really worrying. And that we're not going to win this war. I'm calling it a war. Yeah, it is a war against drugs. I don't know what the international people try to call it, but for me, we need to declare war against drug abuse. And that with the legalization of dagga for home use, I don't think people understand what this thing means and its implications. Because from the kids that I've talked to, some of them think that because Dagga now it's legal, it means it's no longer dangerous. You know, it's like smoking tobacco and or, you know, they've actually reduced that. People don't understand the impact of this later in their lives as kids. And that I think we need to find a way of also of how are we going to involve other departments to seriously partake, not only give support, but you know, to have programs that they are doing as departments. All departments will talk about working with women, children, and youth as their stakeholders. But as years goes, as time goes, honorable members and the chairperson and the department, we may not have a country to run because people who are supposed to run this country immersed in drugs. I mean, in the next 20 years, from kids who started smoking Dagga now when it got legalized in this country, in the next 20 years, where will those kids? You know? And that we are not going to win this war until the serious buy-in. The provincial structures are very important. Then how do we strengthen them? The local development. What happened? I muted. Oh yes, I was muted. I muted myself accidentally. Yeah, I'm just saying that the emphasis should be on strengthening the local drug action committees, and of course the provinces must be strong. But at the same time, what powers do we have as the CDA? You know, where people are not doing what they're supposed to do, what kind of interventions can we, use to make interventions in those departments that are not helping us to stop this scourge. So, honorable members, that's the presentation, and I think members are free to engage. It was more information sharing, even though there are some issues that needs clarity here and there, like the Colombo plan. Is it Colombo or Colombia plan? I really don't understand what this is. If I could be briefed about this. The NGOs that we are funding, that we are partnering with, what impact are they making on, awareness and how's the sharing of information with the police? Because it becomes difficult for members of communities, for instance, to go and apprehend people. And usually when that thing happens is when communities have lost it, and as you know, they'll go ban and kill people, in retaliation to kill the drug dealers. We have seen that happening in Gauteng and other provinces. In the presentation, Chair, you talked about 274 dealers, drug dealers having been arrested in the last years. that is quite an achievement, but I just want to know, what is the conviction rate? Because you had people are arrested, they're out on bail, and next thing, you don't hear anything about the cases. And the impression given because of lack of information is that, oh no, maybe they bribed their way out of prison. Yeah, honorable members, let's check if anyone wants to, those who want to say so. I see the hand of Honorable Baha on the system. Honorable Baha, it's your turn.
Thank you.
Your chance. Sure.
Thank you, Chairperson. Let me apologize for not having my video on. I'm struggling with the connection. Chair, let me welcome the presentation. I think it was elaborate and also gives us a picture of what is happening and how the attempts made to make sure that this covers all provinces, etc. But Chair, I just have three questions that I would like to raise. One, given the fact that we have a drug abuse problem in the country, especially among youth, what are the attempts made to make sure that all departments that are supposed to be part of this initiative do actually take part? Because I think that this should be something that is welcomed by all government departments, and all departments should be putting up their hands to contribute in trying to work out the situation that we find ourselves in. The second one, Chairperson, is about 7 provinces don't have allocated resources. How are provinces expected then to play a meaningful role in the implementation of the drug master plan? And the last one, Chairperson, is, did all institutions, including all government departments, submit their reports in the year under review? If not, what interventions are taken by CDA to address this situation? Thank you, Chairperson.
Thanks, Honorable Baha. Any other comment from the members?
Yes, Chair, I raise my hands. It's Ndongeni.
Oh yeah, just in your hand now. Honorable Dongeni.
Thank you, Chair. I'm sorry about the, I have a challenge of load shedding.
No,
Chair.
it's okay.
It's only one question because almost have been covered with others. On their current status of PASAF, 6 provinces don't have a drug master plan. So do they have a plan to assist these provinces? Since this thing is it's a war, is there anything they have just to assist the provinces and show them how this thing is so important? So it's just one question, Chair. Thanks.
Thanks. Oh, sorry. Continue.
No, I'm fine, Chair. It's just
Okay,
that one question.
Yeah, thanks, Honorable Dongeni, for your input. The other, I think we need to, honorable members, maybe going forward, we need to call a meeting of this the provinces to actually come here and give us a report on what is happening. What is this that they are doing, and what are the challenges that they are faced with? and the kind of interventions, because I think things will differ from province to province in terms of what people do. I know, now let me turn it into in the form of a question. What relationship do we have with traditional healers or traditional doctors in combating this scourge? Because, you know, in my village where I come from, in Skukuniland, there are some few traditional healers who chain people who are brought by their families, the young addicts who are brought by their families. They will chain them and forced during healing or whatever, you know. Some of them are successful. I'm not sure about the others, but what I want to know is that I think there should be a way of coordinating this thing with traditional healers, and also the apostolic churches, the healing churches. I know there is some role that some of the churches are playing in this war against drugs. So have you, as the CDA, met with the Association of Traditional Leaders if there is such a structure? And if not, for me, these are very important stakeholders. Our very important stakeholder will be those traditional healers. And I think we need to find a way of relating with them and having, you know, like structural relationship. There is one in my village, a traditional working, a faith, whatever, healer on. And he has people chained and now that he passed on and there's no one to take over the healing processes, those kids are abandoned now. They're actually sent home back to their parents. So how do we also find a way of integrating this faith healers and traditional healers into our system of dealing with this? Thanks. And if there is no any other hand, I think I'll have to give over to the department to respond. And then, from there, we'll close the meeting and then go into our next meeting as the committee. Honorable Minister, we thank you. You may respond to the questions and the comments.
Okay. Thank you very much, Chairperson. Let's thank the Chairperson for the presentation. Just a few overviews that I would like to suggest. Firstly, I think it would be important for us to support I think a workshop, Chairperson, noting that the information is a lot, but also the trends are constantly changing. Would like to propose for the select committee a workshop that would actually not necessarily be in a presentation form, but as a general workshop where we can actually have a detailed discussion. On issues around the NPOs are funded by social development for what we call statutory services. National funds NPOs that exist in 5 provinces or more, whereas the provinces fund those in their provinces and districts and local government. Let me do this, switch off my camera, Chair, with your permission. Issues around drug and people who use drugs are a statutory sector of a key population, and services to them are from time to time delivered by NPOs. But majority of the NPOs would actually do education and awareness raising, whereas they would also from time to time partner with ourselves to actually run the rehab facilities. At the moment, we are spending 1.7 billion rand to fund NPOs that do extension services in terms of drugs. The cannabis aspect, Chair, you are definitely right. We are waiting for the finalization of the bill, and as social development, we have made inputs in terms of the correct language. Let me also talk to the issues around the types of drugs as well as the designer drugs. Indeed, Chairperson, one of the challenges that affect our rehab facilitation, but also our relapse and our inability to treat and develop what we call confirmed treatment guidelines on rehabilitation is because our drugs changes every day. So one, they also designed. So it's a concoction depending on you bought it from who. So you buy this drug on Monday from Henrietta, on Tuesday, the one you are buying from Pinky. But they are also, which I also need to, for the committee to note, they also highly addictive. So a South African young person, when you compare them with, let's say, a Botswana just next door, as a young people, we experiment. Whether we are in university, there's a part of our lives. The difference is that with a South African young person, it takes one puff and then you are addicted. Whereas the young person in Botswana can use the drugs, for the whole month and then just walk away. That is one of the difficult issues. But we have launched the epidemiological network that is supporting us, and the CDA, so that we are able to actually confirm on what exactly is in our drugs and how do we actually treat them. The Colombo Plan, Chairperson, is a training. It's a Colombo, it's a combination of countries that contribute internationally, but that also serve at the UNODC in Vienna, which is 13 countries, of which South Africa is one of them. And that was started in the 1950s. The core of the plan is to actually build capacity for public servants to understand the issues around addiction, the issues around research. And as South Africa, we have graduate and experts that are on all the 9 provinces, including national government, that have graduated and that continue to graduate on the Colombo Plan. And we are generating and developing what we call experts in the field of drugs, which we did not have in the past. But with the support of the Colombo Plan, we are able to actually develop the skills. Departments, we want to note and to indicate to the committee, we have raised the matter in Parliament. We've raised the matter with the relevant ministers and deputy ministers on their inability to submit their plans, their drug master plans, but also their inability as departments to allocate formal. So that has been raised, and the leader of government business is actually following up for us on the departments. So I just want to say that is happening. The leader of government business is the deputy president. We have presented to him all of the outstanding departments, but also all of the outstanding reports, including the drug master plan, sector specific, that's what we refer to them. With regards to resource allocation, indeed, I want to add to what the chairperson has said. The world of drugs gets sophisticated every single day. At the moment, Chairperson, you don't need to be, in another month or so, we won't be arresting anyone to actually be selling drugs, walking in the street, because everything is now on the internet, which is what we call the dark web. And we can come and present that because it's a session on its own. But also drug users are now, drug dealers are now also using cryptocurrency, which is untraceable. We can make a full presentation on that. So I'm using these examples to just say, for example, social development had allocated nothing more than 7 million to the Central Drug Authority over the years. And we really don't think the CDA can actually take on the world of drugs with 7 million rand. And that has been raised consistently with the National Assembly when we do the budget. And we are hoping that there will be a better understanding of the mandate of the CDA. But we also agree, Chairperson, with the CDA in actually indicating that they really need to be upped. If you look at the South African National AIDS Council, for example, Chairperson, with its independent secretariat in responding to issues around HIV and AIDS at a multi-sectoral, they doing and we are doing very well because that particular decision was taken. Hence, our HIV statistics are going down. So we have made the recommendation that the Central Drug Authority should be constituted with as a multi-sectoral response in line with how the South African National AIDS Council is established, as we believe it will be more successful in that particular structure. Traditional leaders have been trained, Chairperson, all 8,980 of them, including their indunas, kings and queens, for 5 days on social and structural drivers, including their responsibilities. The name of the program that brings in traditional leaders is called The Rock Leadership, which includes everything from drugs to HIV to illegal taverns, what their role is. So it was a detailed 5-day program. We trained them over 3 years, and we only have 500 left, whom we will be training this financial year that started on the 1st of April. With regards to traditional healers, but also the church, it's an ongoing conversation, Chairperson. But as we do the awareness, we are beginning to bring all the stakeholders and understand the importance. We'll be rolling out harm reduction centers, Chairperson, which will include all of the things that the Chairperson spoke about. We also support the Chair in convening as the select committee, all the 9 provinces. This will assist us a lot because as social development, we raise these issues with MECs at MINMEC, and as the select committee will be fully aware that MINMEC is a consensus-seeking structure, and it's there to coordinate. So we hoping that when you actually call them to Parliament, it will send a message that what we have been requesting done is actually becoming a crisis. The issue of language, Chairperson, and a war on drugs, I think we will talk about that when we do the workshop, if it's permissible to the committee, because there's a very specific human rights aspect which South Africa has signed, the 3 conventions, that moves us away from the war language. Because once you go on in war, and then everything goes underground. But also when you go to war, the human rights of people get violated. We have established this network for people who use drugs, which is Sanput, where we are actually getting people who use drugs to the decision table so that we can actually understand where they speak for themselves. We have halfway houses, Chairperson, which I would appreciate if the committee in its oversight can actually visit the halfway houses, because that is where we have all the skills that members were talking about, so that when addicts get out of rehab, they leave with skills, but also we do community mobilization and socialization. As I conclude, looking at the time for the committee, I would just like to indicate that the issue around drugs is a very complicated one. The issues around the opioids, as well as our whole pharmacovigilance as a country, require some overhaul, including the scheduling of drugs and the access thereof. Today, Chairperson, everything you have in your house is a drug. Whether it's your handy Andy, it's your Vim, it's your normal cleaning detergents, it's a drug. Whether it's your cough mixture, all that a child has to do is mix the cough mixture with Sprite and throw in a sweet, and it's called lean. It kills, and children from the age of 3 are able to do the concoction. I'm concluding that to try and say to the select committee, the issue of drugs is a very complicated aspect. It's an octopus with many legs. And I always say to all of us, we are all drug addicts in waiting, because nobody wakes up in the morning from today, I want to be an addict. There are circumstances that happen in our lives, but there's also small things that we do. I know, Chairperson, it's winter, your cough mixture, the doctor said you must drink 5 ml. You just reach for the bottle and you don't even look for the spoon anymore. Anyone that drinks more than 5 cups of coffee is an addict. So the definition of addict in itself, we need to understand it in its totality, because the problem is not the actual use of the drugs or the drugs themselves. The problem is how is these used. With regards to alcohol, we are hard at work. As you would remember, Chairperson, we are pulling. In the past, we had pushed the alcohol industry away and had every reason not to make them pay for the sins that they are creating. But as we engage, and as the chair of the CDA indicated, that interacting and actually dragging the alcohol industry to real programs, real problems, we beginning to also get their attention for them to say, guys, even from advertising, you are making this alcohol thing look so sexy and everybody wants it. But the truth of the matter is, let's go back to lockdown level 5. There's 3 things that happened, Chair, that I'd like the committee to ponder on. The first one is we had the highest number of 9-year to 13-year pregnant young girls. But they were at home with their parents in the families. Nobody can blame the teacher. Nobody can blame the school. Nobody was going nowhere. Secondly, parents failed to look after their children, because it was the first time that we were forced to be sober, and it happened ad hocly. And as parents, we were in the house, but we were unable to parent because we actually alcoholics. It's normal. Every time I come back, my 2 glasses of wine, and then I function. But when the wine is not there, it was the first experience. So we do, as South Africans, have an unhealthy relationship with alcohol. And just to remind the committee, it's nothing new. It comes back even from the apartheid era. The beer halls was the only places where we can meet. We were only allowed to be a group when we are in the beer hall. Alcohol was subsidized, and it's now becoming a generational thing. And we can confirm, as we have developed, Chairperson, which I would love the select committee to be part of, as the portfolio committee has been part of some of the activations of CHOMI, of YOLO, of ROC, the different package, Families Matters, to actually understand the different interventions of social and behavioral change that the department is actually implementing, and that are slowly giving us the results that we are looking for, which is a sober South Africa. Our biggest challenge, children are no longer meeting alcohol at the tavern. They meet alcohol in the home, which then says our interventions need to be focusing more on the family and what is happening inside the house. And that we want to say we are still to get our head around that. And research chairperson, we do have 3 universities that are focusing on alcohol-related research: Stellenbosch, the University of Johannesburg, and the Nelson Mandela University. So with related to alcohol-related research as well as drug-related research that is happening. And I think from there on, Chair, the chair of the CDA, yes, we have a challenge with our local action drug committees. We do have a challenge with our district action drug committees. And the biggest challenge is, Chairperson, is that the lower you go, the more active the actual drug dealers become part of these structures. The local action drug committees, we find that the chairperson is a well-known drug dealer, but because he buries everybody that's dead in the community, it becomes unacceptable and nobody wants to deal with them. So it's not just about municipalities not supporting or municipalities not making resources available. It is also about security, vetting everyone that's on the drug, but also the fear that members of the local action drug committees find themselves from the drug dealers and from their families. So where we are at the moment, being a member of the local action drug committee, it's a risk to your own life, but to the life of your family. So a lot of people are very hesitant to be members of the local action drug committees. And that is one of the, and district action drug committees. And that's one of the biggest challenge that we are experiencing, because there are a few number of local action drug committee members that have been shot and killed while they're doing the awareness, but also their houses burned. And we've had this discussion with SSA and the Justice and Security Cluster, and we are still waiting for response.
Minister,
So
as you conclude.
Yes, I hope I've answered all the questions, Chairperson, but I've also made some recommendations which I hope will be acceptable to the committee. And thank you very much for the opportunity you've granted Social Development and the Central Drug Authority to appear before the Select Committee. Thank you very much, Chairperson.
Thank you. May I just say to the honorable members that since that we are running seriously out of time, we will have to send some of the questions to the department and the CDA in particular to answer in writing. One of the things I'll request is, like today we were given a report on the allocated budget, but what we'll need is a breakdown of budget expenditure for this financial year. I think that would be nicer if we get that. And then if there is need for us to have a discussion further on this matter of the budget expenditure, then we can reschedule it in a meeting and, you know, have a meeting where we'll sit down and look at the things going forward. Let me take this opportunity, DM and you know, the CDA and the department, to thank you for having responded positively to the call for us to meet and look at the, you know, progress that we are making in fighting this scourge. And I think we need, you know, we will send those questions in writing going forward. With these words, thank you very much, and I'll release the department, and so that members can remain in the meeting, so we do our internal stuff.
Thank you very much,
Thank you.
Chairperson, and goodbye.
Thank you,
Thank
Chair.
you.
Thank you, committee
Bye,
members. Bye.
Bye.
Bye, thank you. Bye, thank you. May we look into the minutes? Yeah, thank you. These are minutes of the 30th November. Yeah, the minutes. Members, can we just go page by page? Yes, just there. Are there issues that members would like to raise?
Chair,
Yes. Who's got the oh yeah. I couldn't see the screen. Yes. Any comment on the minutes?
No,
Chair, my
Chair.
hand, Chair,
Hello? Yes.
my hand is up because
Oh, yes,
No,
yes,
Chair,
Honorable. I'm trying to
I
get
wanted
to the picture here, but I can't see. Oh yeah, now I can see your hand is up. Yeah. Over to you, Honorable.
Yeah.
Nkosi.
No, thank you very much, Chair. I wanted to say the minutes presented before us are a true reflection of what we have discussed on that day. Therefore, I move for the adoption of the minutes as true reflection. Thank you.
Any seconder? Thank you. Any seconder?
Ndungeni, Chair, seconded.
Don't go any second. Yes, thank you. Is there another? Is there another set of minutes, Marcel?
Yes, Chairperson, I'm trying to load the second set of minutes.
Okay. Thank you. Thank you very much, Marcel. I can see that. These are minutes of the meeting of the 14th of March. Here they are. Let's go down. Yes. Okay, honorable members, there are the minutes. Any comment, any correction? Comments, corrections, nothing? Any mover?
Ndungeni moves for the adoption, Chair.
Don't get any moves, any seconder?
Because the seconds, Chair.
Good second, thank you very much.
Chairperson, we'll do the last set of minutes now.
Yeah, the last set of minutes, yes. Yeah, the minutes, honorable members. That's wait a bit. I was on a, yeah, any, okay. No, but this is 22nd November 2022.
Yes, Chairperson, this is the last set of minutes. It was the minute from last year that we did not
From
get a
last
chance
year,
to
yeah.
adopt.
Okay.
Yes.
Any mover for, okay, any comments or corrections on this? None.
Chairperson. Chair,
Yes.
no corruption, no comments. I move for the acceptance of the minutes.
Honorable Mkosi moves. Any seconder?
Baha seconds, Chairperson.
Baha seconds. Baie dankie, meneer Agbare. Baie dankie. This will be the end of our set of minutes. Is there any other matter that you want us to discuss? Is there any other thing that you think we should discuss, Marcel?
Thank you, Chair. Chair, I just wanted to raise, I'd spoken to you earlier about the committee's APP. I'm not sure, the APP was discussed, I think, at the NCOP strat planning session. Unfortunately, that session came to an end due to the unfortunate incident with Chairperson Gillian. I'm not sure in terms of where the committees now stand in terms of adopting that particular report, or if it was completed at that particular session, Chair. If you can perhaps offer some guidance. Thank you, Chair.
Yeah, it was a very difficult time. I just want to check with the with Molo, no, our researchers. What's the progress with the? I don't remember whether we had a discussion or it was said that because we had discussed quite a lot that a report will be. I was talking to myself, this was muted, sorry. Now saying, we all know what happened on that day. And, but the major part of the work was done. I just want to check with the researchers if they managed to compile something that can be adopted, or maybe we should talk about this outside the meeting. What do you suggest?
Chairperson Tabile's hand is raised, Chair.
Good afternoon, Chairperson and members and colleagues.
To open this thing, so actually I keep on losing the network. Whose hand is up?
It's Tabile, Chairperson.
Oh yes, it's Tabile. Yes, ma'am.
Yes. So basically, what we were presenting there that day, we had already drafted into a document. What we could do is perhaps share the document, the Word document that we had prepared, share it with the members. And I don't know whether we would want to reconvene or just perhaps members could email myself or ourselves directly and propose any amendments or changes that then we could consolidate and finalize the document.
Okay, can we say maybe we give members this time to look into those, and then next week when we have a slot, we can look at the program and adopt it or do the changes. But members can write if they, after looking at this, they can suggest to the researchers what needs to be changed or what needs to be added to the report.
Yes.
Is that in order? Honorable members,
We agree,
will that
Chair.
be in order? Okay.
Agreed, Chair.
No, thanks. Honorable Nkosi, your hand is up, or is it?
Chair, it's a legacy
old
hand, I'm
hand.
sorry. Yes.
With the legacy. Thank you very much. On members, thank you for responding positively to this invite. And yeah, we'll keep each other wired. If there are issues, questions that members feel they were not answered and they want us to send them to the department, we can send them to through Marcel to the department for further answers. Thank you very much, and this meeting is adjourned. Bye, Danke.
Bye, Danke, Chair.
Oh, yeah, at long last.
Thank you.
Sure.
Thank you, Akbara Baha.
Enkosi Pelagari.
Okay.